morning, ladies and gentlemen, and congratulations to the NNI team for being able to start this this legacy meeting once again in person. Of course, technology is a great enabler. We saw how robotics can potentially change things for us, but sometimes it can also play a spoil sport, as it happened in the morning. Vitor just couldn't log in. But we are grateful that Prof. Anchali at least has managed to be in person. So yes, it's still good to travel and attend meetings in person, not always online. But yes, but if it's raining like the way it is outside, even I felt like whether I can talk from home. You know, I mean, don't have to drive through the heavy La Nina effect that is going on in Singapore. Yeah, over the next 20 minutes or so, I shall speak a bit about the role of, is my slides out there? It's not there, right? Is it displayed? No, right? Oh, yeah, okay. Yeah, I'll be speaking about the role of middle meningeal artery embolization for chronic subdural hematomas. Now, this is a relatively new treatment for an old malady. A recalcitrant problem, that is chronic SDH. We drain it surgically, they keep recurring, and that's why in last few years, I think in the last 4 or 5 years, there have been several case reports, case series that have emerged, which has shown that this treatment can be quite effective. And at present, there are several ongoing randomized controlled trials, so I'm fairly confident that very soon we'll be having a lot of good level of high quality evidence as well to support this treatment. My conflicts of interest not very relevant to this subject. Now, chronic subdural hematoma is a problem of old age. For a country, for a society like ours, where 1 out of every 4 persons is going to be more than 65 years of age, in the next 7 to 8 years, we are actually facing a looming danger out here. And yes, chronic SDH doesn't kill a patient the way an aneurysmal subarachnoid bleed can do, but the problem with this condition is that once someone has an CSDH, the likelihood of that person going back to independent life at home, to an independent quality of life, is less than 50%. And in fact, the cascade of events that this disease often sets into motion is such that around 30% of people won't survive beyond 6 to 12 months after the event. Sorry. Okay. Will not survive beyond 6 to 12 months from the event. Surgical treatment is the standard of care, but the problem with surgery is that surgery for CSDH is just like giving Panadol for headache. You're just dealing with the symptom, the end product, but not the source. We're not dealing with the pathophysiology, as I would share with you very soon. Small collections can get absorbed by itself, it will resolve by itself, but if you have a bigger collection, which is more than 10 or 15 millimeter in size, or you have a symptomatic SDH, the likelihood of spontaneous resolution is very less, and often you have to resort to surgical drainage. Surgical drainage works well, but the problem is recurrence. And these recurrences are, you can see, it's anywhere in the range of 10 to 30%, depending on the kind of surgical approach is taken. Of course, if you do very aggressive surgery like a membranectomy, that risk may be, the recurrence rate may be lower, but of course, membranectomy is a very morbid procedure, even mortality involved, so of course, not a preferred one. So yes, surgery works, but surgery is plagued by recurrences, and recurrences are especially common in the elderly people with diabetes, liver disease, also on anticoagulation. And in fact, if you think of the population who gets CSDH, most of them are actually at risk for this kind of recurrences. From a medical standpoint, many things have been tried, but for all practical purposes, if something has been shown to be of value, it is atorvastatin. Now, statins here are not used for their lipid-lowering abilities, but more for their anti-inflammatory properties and their ability to promote vascular maturation. This randomized controlled trial from a Chinese group has actually quite nicely shown that by using statins, you can reduce the need for surgical evacuation for these patients and also help in reducing the thickness of the subdural collection. However, most of the times it's not adequate, and that's the reason why almost 60 to 70,000 patients, like that's American data, in the States 60 to 70,000 patients every year go for surgical evacuation. That's where MMA embolization comes into picture. Now almost the last 70 years or so, the medical community has been obsessed with the theory of the veins traversing the subdural space get stretched, torn, and cause SDH. I'm not saying that theory is wrong. It contributes in some cases, but that's not all that is there's more to it. We often neglect the inflammatory component behind the chronicity of SDH. And actually the inflammatory component was speculated or rather suggested by Verco almost 150 years or 170 years back. But unfortunately, it got neglected until recent times, maybe in the last 10 years or so. Now we have realized that at least the currently accepted theory is that there are dural cell layers, dural border cells. There's a layer of dural border cells between the brain and the dura, and any kind of trauma, even a minor trauma, can sometimes cause tears and splits in these dural cell layers. And this splitting of the, sorry, can we switch it off? It's just flickering continuously. It's very disturbing. Just flickering. Just switch it off. Thanks. So this splits in the dural cell layer, promotes entry of inflammatory cells into the layer, and these inflammatory cells release cytokines and other bioactive substances which promote formation of neomembranes. These neomembranes are very leaky, have fragile vessels. They cause more leakage, more exudation, more inflammatory cells. It's a kind of self-perpetuating cycle that is set into motion, and we get these collections becoming bigger and bigger. So what does middle meningeal artery embolization tries to achieve over here? MMA embolization tries to cause ischemia of these membranes and thereby helps in reducing, or at least attempts to reduce the exudation from these leaky membranes to achieve a state where the resorption rate is higher than the rate of leakage, so that eventually the collection will resolve and the membrane, the space will collapse. This example I'm showing you just to provide an imaging evidence of the leaky vascular network theory about which I was speaking. This was a CSDH patient who went for MMA embolization, and when we did a cone beam CT immediately after the embolization, you can see that there is contrast layering in the SDH and the membranes are actually enhancing, which means that anything that we are injecting through the middle meningeal artery is reaching into that subdural collection. So naturally, it's very intuitive that even our embolic agents can potentially reach even if the embolic agents don't reach at least they can reduce the blood supply to that region, and that may be enough to achieve the results that we want. It has been published as well before. So what are the indications for middle meningeal artery embolization in chronic SDH? It's primarily, the most frequent indication is dealing with recurrent collections after surgical drainage, that is a rescue middle meningeal artery embolization. More recently, a prophylactic or adjunctive embolization, where the embolization is done together with a surgical procedure, is getting a lot of traction because it can reduce the likelihood of recurrence, make surgery more effective, and overall reduce the cost to the healthcare system. And there are also some scenarios where we can offer primary embolization or an upfront embolization. A primary or upfront embolization is usually meant for those high-risk patients for surgery, or even those polysymptomatic patients who are at higher risk of the collection enlarging, like those on anticoagulation or having liver disease. From a technical standpoint, it could be done by transfemoral or transradial route. Particles, liquids all seem to work well, but particles is what have been reported the most in at least the published series. More recently, embolization with liquid embolics is getting more popular. And if you want, you can actually treat both the sides simultaneously, although many places recommend going on a serial way for if there's a bilateral collection. And one of the beautiful things about this procedure is that you don't have to worry the patient is on anticoagulation, antiplatelets. You don't have to stop the rivaroxaban. You don't have to stop the heparin. Just wait for 4 hours, stop the heparin for 4 hours, do the treatment, and everything is good to go. You don't have to worry about warfarin. So because you can do these procedures most of the times through a transradial access. And of course, if you're embarking on a MMA embolization, you need to have a reasonable understanding of the anatomy. I wouldn't go into details of that. These 3 articles that are listed out there are quite good for that purpose. You can just go through them. They're very much in detail. If you don't want to know the details, just remember the general principles or the most frequent anatomy. The middle meningeal artery arises usually from the internal maxillary artery and enters through the foramen spinosum into the skull, and is around that segment where it's entering the foramen spinosum or traveling through foramen spinosum where most of the crucial branches come out from. The branches which can supply the facial nerve, the petrosal nerve. So if you are embolizing, be careful, stay away from that. If you are more distal, the likelihood of injuring any of these petrosal nerves or the cavernous branches which supplies the Meckel's ganglia or sometimes even communicates with the inferiolateral trunk of the cavernous IC, all this can be avoided. And other thing to look out for is a communication with the ophthalmic artery. Almost always there will be some kind of communication. It just depends on what is the size of the communication between the ophthalmic artery and the frontal division of the middle meningeal artery. Okay, I think in interest of time I'll skip that. Yeah, so this is something I already covered. Yeah, this one, yeah, we can see the petrosal branch. The petrosal branch can be sometimes confused with the petroscomosal branch. So the easy way to differentiate is by looking at the frontal images. On the frontal images, the petroscomosal, petrous branches go superiorly, where the petroscomosals are running more laterally. And of course, that's a communication with the ophthalmic artery. And this is a case where actually a selective MMA angiogram is showing opacification of the middle cerebral artery. So we have to be aware of such possible communications and try and avoid them. How I do my middle meningeal artery embolizations, I'll just share it with some cases. This was a patient who had 2 surgical evacuations before and he still got a recurrence. So he came for the treatment. We went transradial. Usually a 4 French sheath is enough. For ipsilateral ICA, I prefer to use the renal double curve catheter, and for the contralateral, it's usually the soft SIM2 catheter for cannulating the ICA and the CCA. And I would suggest that it's good to always do a CCA and ICA angiogram for these patients. The main benefit being you want to know that there is no carotid stenosis, because if there is an ICA stenosis anywhere, there's a high likelihood that they may have communications, that is dural vessels and the PL arteries may have communications. This autosynangiosis can be a lethal problem if you don't realize that and go and embolize the dural vessels. Similarly, IC angiogram also will help you identify the ophthalmic artery, because if you don't see an ophthalmic artery arising from the ICA, well, we have to be more careful there. Yeah, so this is a selective angiogram that's showing the vital branches I was referring to. And here you can see the cotton wool appearance, which has been frequently described in the literature. It's because of the blush or the staining of the contrast staining of the membranes of the SDH. In this case, yeah, we went selectively into a fairly distal or a mid-distal kind of location and embolized with particles. Now, if you're using particles, you don't go too distal, because if you go too distal, we will wedge the catheter and the particles won't flow forward. I'm sure most of you know that for particles to reach the vascular bed, there should be reasonable blood flow. Blood has to push the particles forward. It's very different than glue or other liquid embolic agents. And so this was a completion angiogram, and this is the post-procedure 6-week CT scan. Most of the collection has resolved. Coronal and axial images. It's more than 1.5 years, and this patient has not had any other recurrence. Other similar case, and same thing. We did a middle meningeal artery embolization, went into each of the branches separately, and here you can see that the frontal branch is very close to the origin of the ophthalmic artery. So if you see such close communication, either you have to go very distal from this communication to use particles, or sometimes you can just leave it alone. I do tend to leave them alone, and results are not that too bad. Otherwise, you can just coil it off. It's safer. But particles from such position could sometimes be dangerous. Yeah, this was embolized with 250 micron embosines, and that was the subsequent results. Good response. Third case, yeah, this patient had a rebleed and he was of course symptomatic, so we couldn't straight away go for MMA embolization. He went for evacuation first and immediately on the next day came for the embolization. But in this case, if you look over here, this is, oops, okay. From the posterior division, it looks good, so I just embolized with particles. But here, no, actually posterior branch also used liquid embolics here. You can see this opacification of the veins. There's a shunt out there. That's because it's at the margin of the surgical bed. I mean, the craniotomy was at this site, and that's why there is a shunt from the artery into the vein. There's a meningeal artery to vein. So instead of using liquids, I used instead of using particles, I use a liquid embolic agent, and you can see the distribution of the liquid embolic. It's penetrated fairly well, and that's the follow-up CT at 2 months. Very good response to the treatment. Yeah, this was one of the first cases where we did a primary MMA embolization. That was, no surgery was done. Patient was in liver failure or other Child's B cirrhosis. 20K was the platelets on anticoagulation, so very poor surgical risk case. So the only treatment we offered for him was embolization. Again, the same thing, ECA angiogram, and yeah, you can see the tortuosity. Now, this is something that you'll frequently see. These kind of tortuous arteries are frequently encountered, and they're very misleading. It appears that it's easy to navigate, and you know, I mean, usually when you're dealing with dural AVFs, we tend to cross these kind of arteries quite easily, but I've seen that for these MMA embolization patients where the arteries are not very hypertrophied, the wire may go, but when you try to cross these tortuosities with catheters, you may end causing dissections or perforations, and actually that's what happened in this case. I dissected this artery so well, embolized the distal, the posterior division, but this branch I couldn't use particles, so I just coiled it off, and in spite of that, actually we got very good results. So that's why I said in the beginning, although selective embolization is what is generally recommended and considered to be better, truncal embolization also may not be too bad if selective is too difficult or not possible to do. Another case, which is just to show the similar tortuous anatomy. Again, the posterior division, which was straight anatomy, I crossed it and embolized with particles. The anterior divisions got very tortuous anatomy. After having perforated them before, I didn't want to do the same thing. So this time I didn't try to cross the tortuosity. I just injected liquid embolics and did the same thing for the opposite side as well. It's like a very tortuous anatomy, and this is the subsequent. You can see in both the anterior divisions is a fairly good penetration. So when you're injecting liquid embolics for these arteries, it's actually very fast injection. You just have a few minutes. It's unlike this. It's very unlike the usual plug and push, because you don't have too much of opportunity to plug and push. You just inject whatever goes, and it usually goes very well. Is good, and that's why using less viscous or less viscous agents can be quite useful. Now this is, this case was done quite early this year, in the early part of this year, a youngish guy, and the same thing. Here we directly used liquid embolic agents for both the anterior and posterior divisions, and yeah, it was squid that was used, and you can see the penetration was good. In fact, sometimes we have seen that you just inject liquid embolic agent into one of the branches, that is the posterior division. It will go through the anastomotic communications into the anterior division as well. That is, you may not have to actually cannulate both of them separately. That's a post-treatment CT scan. So between liquids and embolic, liquids and particle embolics, is there a difference? I don't think there is one superior over other. Each of them had their own benefits and limitations. Now, particles are definitely cheaper. You can do particle embolization with just one single catheter. But the problem with particles are if you cannot go fairly distal, you are scared where it's going to go. And there's a general thought that particles are a bit more forgiving, but I'm not sure it's right or wrong. And when it comes to liquids, yes, you have to keep changing your microcatheter. At least 2 microcatheters is required, which means that the cost is higher. Again, the liquid embolics themselves are more expensive than particle embolics. But of course, if you're dealing with a tortuous anatomy, probably liquid embolics are better, because you can inject from a fairly more proximal position than with particles. And another benefit is that you can see where they are going. You can see the embolic agent if you're using a liquid embolic agent. And personally, I realized that when I use liquid embolic agent, the radiation to the operator and the patient is probably less, because injection is faster, whereas with particles, we actually have to inject through a long time. From a clinical evidence point of view, there are several case series and some prospectively maintained series as well. No randomized control trial as of now. This one I selected because it has fairly big number of patients, and they're looking at a more homogeneous kind of population, and you can see the technical success rate is 97%. Around half of the patients were treated under GA. And outcome-wise, more than 70% of the patients got reduction in the thickness of the SDH by more than 50%, and only 6% or so required a surgical drainage at 3 months from the embolization. And the other good thing to note is that disease control. That is, in 96% of the patients after the embolization, there was no progression of the disease. This paper is selectively looking at the high-risk population, those people who are more than 65 years of age. They also had a very elderly group, which was more than 80 years of age, and they still could get fairly similar comparable results. That is, disease control was more than 90%, and reduction in the thickness of the collection was more than 60%, and surgical rescue was recorded in a very small number of patients. Complication rates were fairly acceptable. I'll skip this. Yeah, this is an interesting paper from, I think, last month, published in JNS. It actually is coming from the Baylor Institute. They found that by doing MMA embolization, you can actually reduce the cost for the patient's care. It has been shown that by MMA embolization, the overall duration of hospitalization also is reduced for these patients with CSDH. I'll skip this one as well. I think in interest of time, I'll just skip this. Yeah, I'll just come to this meta-analysis, which looked at several other series and compared the role of MMA embolization as against the conventional management. And you can see recurrence. The forest chart is very much in the direction of MMA embolization. It does better even in terms of need for surgical retreatment. In-hospital complication is a bit more towards the neutral, but still in favor of MMA embolization. They also did, I think I'll skip this part. So in conclusion, MMA embolization seems to be promising treatment for this recalcitrant patients with recurrent SDHs. And currently there are several ongoing RCTs. Many of them are industry sponsored. At the same time, an equal number of them seem to be PI initiated. And they're doing it very nicely. They're not trying to replace MMA embolization, replace surgery with MMA embolization. They're trying to show that by adding MMA embolization to the standard of care, how does it impact the patient's final outcomes and the total cost to the healthcare system? Because this has a lot of the cost bearings and social connotations as well. Thank you for your attention.